Welcome to The Code Trade, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
And now we will have Joe Champoux, who is a PGY2 emergency medicine resident at Detroit Receiving Hospital, and he'll be presenting a journal club on haloperidol versus ketamine for managing acute agitation in the ED.
So I have no conflicts of interest to disclose. A little bit about some of the background we have. So agitation is considered to be this state of extreme arousal and restlessness that's typically caused by a wide variety of conditions, and it poses a significant risk to both patients and healthcare workers, especially in the emergency department. Management of agitation includes both non-pharmacologic interventions, such as like verbal de-escalation, and pharmacologic options. Some of the pharmacologic agents that typically come to mind when we're thinking of managing these agitated patients include benzodiazepines. Typically, this is going to be lorazepam or midazolam. However, these ones are going to be associated with a risk of respiratory depression. Other classes may include typical antipsychotics, such as haloperidol, droperidol, who each come with their own list of side effects. QTC prolongation is usually one we tend to think about a lot with those. Atypical antipsychotics, I have olanzapine here. Again, QTC prolongation going to be one of the more concerning side effects. And then dissociative anesthetics, such as ketamine, that also come with their own unique side effects, such as laryngospasm and emergent reactions. So briefly looking at what the 2024 emergency physician group kind of put out there for their recommendations. So when it comes to like these severely agitated patients within the ER, they actually have no level A recommendations when it comes to this. They've started out saying, consider trying non-pharmacologic interventions and moving into a pharmacologic if needed. When it comes to pharmacologic, there's not necessarily a preferred one that should always be given when it comes to level A of degree of recommendation. Then we move into level B. So now it's these benefits will likely outweigh any risk. We see that droperidol and midazolam combination therapy is their preferred first-line treatment regimen, then followed by either giving droperidol with maybe an atypical antipsychotic, and then going to haloperidol plus or minus lorazepam with that. And then we have level C, where ketamine IV or IM is recommended. However, this is level C, meaning that there is some more concern of possible safety events or side effects that might occur with it. And that's kind of why it's lower in the recommendations than our initial agents in level B. So kind of going through into some of the medications that are studied in this study, we see haloperidol. So it is a competitive dopamine receptor antagonist. However, it also has a lot of off-target effects, including alpha-1 antagonism, muscarinic receptor antagonism, and then histaminergic effects as well. It can be given IV or IM, and it's typically 2 to 10 milligrams. However, our typical practice, I feel, is that we're either giving 5 or 10 milligrams when it comes to these patients. It's fairly quick IV when it comes to giving it, so about 15-20 minutes. IM is a little bit longer, at about 20 to 45 minutes, and its duration can grossly vary depending on how the patient responds to it. And again, has a few varying side effects, but QTC prolongation being the most concerning when we're thinking about it in the ER. Next, we have ketamine. So it's an NMDA receptor antagonist that can be given IV or IM. Typically, it's going to be a weight-based dose. It's going to be increased when we're given an IM compared to IV. Its onset is much faster than haloperidol, starting within seconds when it comes to intravenous route and taking within minutes, less than 10 minutes when it comes to intramuscular. Its duration is not as long as haloperidol is. It's about 10 minutes for IV, 10 to 25-ish for IM. And then again, some of its side effects, including like respiratory depression and emergence reactions. Some of the background literature that's been conducted comparing this now, especially ketamine's role when it comes to this. So this was a prospective open label observational study that was conducted in 2016, in which EMS was equipped for the first 6 months of the study with 10 milligrams of IM haloperidol, which they could give to their agitated patients. And then the second half of the study, or the second 6 months of that, they were given 5 milligram per kilogram IM ketamine that they would give to their agitated patients. The main goal of this study was really determining if haloperidol or ketamine was going to be superior when it comes to pre-hospital agitation. Some of the secondary effects they're looking at were like repeat dosing, adverse effects, and rates of intubation. What we saw in this study was that ketamine had a much faster time to adequate sedation, and it was not necessarily requiring as much required additional dosing. However, our rates of intubation and adverse events overall were significantly higher with ketamine compared to haloperidol. The conclusions they made at the time was that ketamine provides faster time to sedation. However, the clinical benefits of that faster time need to be significantly weighed against the higher risk of adverse events. 2018 now, we have a prospective randomized double-blind trial conducted at 2 medical centers outside of the US. These patients were given either 5 milligrams of IM haloperidol or 4 mg per kg of IM ketamine. The main goal that they were looking at here was a time to adequate sedation of AMSS of 1 or greater. Secondary outcomes we see here were needing, again, for additional agents, rates of intubation, and rates of side effects. Similarly, they saw that there was a much faster time to sedation with ketamine. However, this one did find a little bit different in that ketamine often needed to be maybe repeated more, but this was a non-significant finding. And then the intubation rates and side effects were no significant difference now between haloperidol and ketamine. So they found that ketamine at a 4 mg per kg IM dose was able to provide enough rapid adequate sedation. However, they recommended possible further research looking at the safety of ketamine. And then lastly, done in 2020 was a case series conducted at a single large academic medical center in which they looked at 15 cases of patients that got ketamine at a 2 milligram per kilogram IM dose, max of 200, and then additional dosing if needed. They were mostly looking at efficacy and safety when it comes to this. They saw that the rough mean total dose was about 150, a little over milligrams. The mean weight-based dose, again, being 2 milligrams per kilogram. They only reported 1 case of intubation. However, this was attributed to being more refractory agitation and not actually from the ketamine. And they reported 0 adverse effects. So from this study, they actually recommended that a 2 milligram per kilogram dose of ketamine IM is very safe and efficacious, but further research is going to be needed. Kind of leading into our trial that we have here today of looking at haloperidol versus ketamine for managing acute agitation in the ER. So this was a blinded trial that had block randomization in which they did 2 haloperidol and then they did 2 ketamine when it came to their block randomization. Again, this was at 2 large medical centers outside of the US from March of 2021 to March of 2022. They calculated that they needed a sample size of 120 patients, 16 each group, to be able to find significance. And the intervention they did was haloperidol 5 milligrams IV push versus ketamine, a 2 milligram per kilogram IV push. Both were diluted into a total of 10 mLs, 0.9% saline, so that it was going to be blinded still. The study population we were looking at here included 18 to 65-year-olds that were presenting with acute agitation that was requiring acute intervention. Exclusion criteria included those that had improvement with non-pharmacologic interventions, if their RAS score was below 1 or less, if they had any sensitivities to the drug, if they had a baseline prolonged QT interval, pregnant or lactating, or if they were treated with benzos or any neuroleptics within 24 hours prior to presenting to the ED. The primary outcome they were looking at was management of their Richmond Agitation Sedation Scale score, or RAS, of acute agitation of 1 plus 1 or greater, and they were looking for a response if it decreased by 1 or more to consider that significant. Secondary outcomes included incidence of adverse effects and then time to onset of therapeutic effects. So briefly, just looking over the RAS score, we see that the higher, the more positive the number is, the more agitated, more combative they are, compared to the lower the score, being more unarousable state. Some of the stats, so their categorical data, they use chi-square and Fisher's exact testing. For continuous data, they use t-test and Mann-Whitney U, and then they define anything statistically significant of having a p-value of less than 0.05. So when we look at their patient selection, we see that they ended up randomizing 127 patients now, and then breaking that up in 2 groups in which they're allocated into 1660. So here we see that within the total population, they were able to meet that power goal of having at least 120 patients of 60 in each group. When we look at the background characteristics, there was nothing really significantly reported here. We saw age roughly being about the same at about 45 to 50, and then a similar percentage of the groups being male of about 3/4 or 75-ish%, both having males in their patient groups. When we look at the primary outcome of the study, we see baseline RAS is pretty similar at about 1.7, 1.6, and that the secondary RAS, or the RAS that was measured immediately after, we see it was 0.07 and negative 0.092 between the two groups, which was considered to be statistically significant between haloperidol and the ketamine, and there was a significant decrease between the pre and the post RAS change. So that RAS change total, we see ketamine's average was about negative 2.5 versus haloperidol, which is about negative 1.6. Now looking at secondary outcomes, we see that the systolic blood pressure we have before, after the intervention was given, and then the mean difference here. In the haloperidol group, we see that the blood pressure was there was a significant decrease in blood pressure before and after haloperidol was given. However, when we look at ketamine, there was no significant difference within those patients' systolic blood pressures. When we compare them across the groups between haloperidol and ketamine, we see that the mean difference and the after intervention blood pressure were both significantly lower than with haloperidol than they were with ketamine. Similar with the heart rate group, we see that before and after with haloperidol, we see that there is a significant decrease within the group, and there was a significant decrease noted as well within the ketamine group. However, this was an actual increase compared to a decrease that we see with haloperidol. And when you compare the mean differences between the two groups of haloperidol and ketamine, we see that there is a significant difference, which would make sense because ketamine's increasing our heart rate, where haloperidol was decreasing the heart rate. Now looking at time to max effect, so this was what they consider to be adequate sedation at the point. So roughly took about 19.67 minutes, or about 20 minutes for haloperidol to meet the max sedatory effect, compared to ketamine, which is closer to about 10 minutes here, which was significantly faster with ketamine than haloperidol. Repeat dosing was needed in about 20% of the haloperidol patients and about 13.3% of ketamine patients. However, this was no significant difference here. The rates of intubation, again, was no significant difference between the two, with 8% in haloperidol and 6% in the ketamine groups. So the authors' conclusions that they came to here were that they found that ketamine demonstrated much faster onset of action. It reduced agitation levels much more rapidly than haloperidol did. Both agents did have their side effects that they were associated with, and that safety profile of ketamine might further, again, more investigation, and that further research trials should maybe start to focus on much larger, more multi-centers trials instead of just having one or two centers. Some strengths of the study were that it was a randomized trial, and it was blinded, which gives it some more credibility. And the RAS score is a much more feasible measure of outcome. It's much easier for our nurses to be able to do bedside. Some limitations that we see here is that it was a restricted sample size, so they met power within their calculation. However, it was still a smaller sample size, and this was conducted outside of the U.S. at 2 foreign medical centers. So some kind of key takeaways to take from this study would be that ketamine provides a much faster time to effect than the haloperidol does, and it does have few side effects, or at least no more side effects than haloperidol had when it came to the comparison of some of our significant ones that we saw. Identifying the underlying cause for the agitation is going to be probably one of the most important things that we have to do, just because being able to solve that root problem is where we're going to get the most efficacy out of our treatments, instead of just continuing to further pharmacologically sedate patients. And of course, further research is going to be needed. I'd like to see maybe some other comparisons that are done with other antipsychotics. So when we look back at the ACCP guidelines, droperidol is their preferred agent. So I'd like to see maybe some more studies that are done comparing droperidol to ketamine in this sense. And with that, I am happy to answer any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.